Welcome to this session called Evolving PCI Devices, Coronary DES, BRS, and DCB. My name is Fahim Jafary. I'm from Singapore. My co-chair is Dr. Bruno Scheller, who really needs no introduction, world authority on the subject. We have an awesome set of panelists. To my left, Dr. Ziad Ali, again, who needs no introduction. On the right side, we have Dr. Sandeep, Dr. Joo-Yong Hahn, Dr. Yuji Hamazaki, Dr. Soo-Joong Kim, Dr. Kambis Mashiaki, Dr. Eun-Seok Shin, and Dr. Simon Walsh. Again, I think most of the panelists are here and need no introduction. So without further ado, I'm going to invite the first speaker, Dr. David Cohen from the US. Again, needs no introduction. He's going to talk about novel drug-eluting stent designs, not yet Plateau, still need to go.
Thank you very much. It's a pleasure to be back here at TCT Asia Pacific and to talk about new drug-eluting stent designs. I always learn from giving this talk because I didn't really know we had any new drug-eluting stent designs, but we do. These are my disclosures. So the first question, I think the motivation for this entire session is, aren't current drug-eluting stents, they're awfully good. Aren't they good enough? And the data would suggest that they are better. These are data from Mahesh Madhavan and Greg Stone and colleagues looking at target lesion failure with early generation drug-eluting stents, and then specifically with cobalt chromium EES, as well as bioresorbable vascular scaffolds. And what we see, after 12 months, a steady increase of about 2% per year with first generation DES, which is now down to about 1.5% per year with the second generation and third generation devices. But still, there is some place to go. There is something to be prevented. So I think that's the motivation for this talk. So there are two basic platforms that I see out there that are being experimented with. Obviously, there are new and different versions of conventional drug-eluting stents, bioabsorbable polymers, all those things. But those are really, again, just iterative. These are some really new systems that are very interesting. So one of these are these stent polymer hybrid systems. And probably the best example of this is the Dynamics Coronary bioadapter. They don't even call it a stent. They don't want to be confused with a stent. And the idea of this system, this is from Elixir, and it is a scaffold, or a bioadapter, as they call it, that's made up of sinusoidal strands, so basically helixes, but they're only connected at these little bridge points by a polymer. And so the idea is that they go in, and it's like a conventional stent, and then over 6 months that polymer resorbs, and then all of the individual links are detached. And then again, this is what it theoretically looks like. This is a animal model, looking here at the pulsatility early after implant with essentially none, and then by 6 months the bioadapter, it releases and it's uncaged, and then what you see here is the result of that, where there is more flexibility in the vessel and some ability of the vessel to pulse, which has theoretical advantages, and we will see over time whether these translate into real advantages. Again, you still get some vascular support, but you get much more vessel flexibility. The whole issue of vessel straightening that we get, especially in tortuous vessels, should be improved by these devices. The first randomized trial of this device was presented last year at EuroPCR, the Dynamics bioadapter versus Resolute Onyx, a relatively small study with a lot of mechanistic sub-studies. The primary outcomes are shown here. Target lesion failure met the criteria for non-inferiority with the Dynamics compared to the Resolute Onyx. There were no important differences in very low rates of all of the different component endpoints, including definite or probable stent thrombosis. What was interesting was in a small subset of patients who underwent angiographic follow-up, there were what looked like important trends towards reductions in late lumen loss with the Dynamics device compared to the Resolute Onyx, small vessels, LAD, long lesions. Again, very small numbers though, so I think we have to really see what that translates into. And then they did do a imaging study with IVUS to look specifically at this pulsatility and the area change during the cardiac cycle at different positions, and they saw significant differences, again, reflecting that restoration of vascular pulsatility with the resorption. The good news is we are going to have a relatively definitive trial of this device presented later this year. The Sweetheart trial, 2,400 patients randomized to the Dynamics bioadapter versus Resolute Onyx, and the results are expected from this in the fall of 2024, so I guess that means either ESC or TCT, so stay tuned and pay attention. I think it will be very interesting, although I think the longer-term follow-up is really going to be where this device might shine. Another device, sort of a similar idea of detaching the sinusoidal elements from the longitudinal elements, is the Ioneer device from Mednol. This is kind of what it looks like in cartoon form, but the idea is it has a radial structure that's metallic, and then it's got these polymeric strands that connect all of the metallic elements in order to give it longitudinal support. And the idea, again, is that the vessel is uncaged over time as those polymeric strands resorb. So it's a spiral design. Again, with high radial strength, gives good radial support, but there are no lengthwise connections, and so as a result, even early on, it has quite a bit of flexibility because again, all that's connecting these sinusoids are polymeric connectors, and again, it's got a fairly low footprint. And then the other advantage of this, again, with this polymeric mesh, it's very, very thin strands, 3 to 5 microns, so smaller than a red blood cell. The spaces between these strands allow the red blood cells to pass into all the little side branches, so there should not be any concerns about a side branch obstruction from this polymer. And the idea, again, is that over about 3 months or so, all that polymer mesh resorbs, and again, the vessels look very, very nice, but what really is happening from that polymer is that's where the drugs are being eluted from. And so in contrast to what you get with a conventional drug-eluting stent, where there are hot spots, where the drug is only being eluted from the stent itself, which only contacts about 15% of the vessel wall, with the Ioneer device, the drug is being eluted from that entire mesh, and so there are no hot spots. You get very uniform distribution of the drug, and you should be able to get similar levels of inhibition of neointimal hyperplasia with less total drug dose. Whether that turns into something useful, time will tell. There's a first-in-man study going on in Israel and Brazil that is just a single-arm study with a number of imaging endpoints, and we will see shortly what those results turn out to be. Finally, the last device that I want to just touch on is a combination therapy drug-eluting stent. This is also from Elixir, ironically. It's called the Design BDS, and this is a triple drug-eluting platform. So it has sirolimus, well-known antiproliferative drug. It has argatroban, a direct thrombin inhibitor, as well as rivaroxaban, a prothrombin inhibitor. So it's got 2 antithrombotic agents and an antiproliferation drug, all of which are embedded in the same bioresorbable polymer and released over the first 3 to 6 months. And at least in AV shunt model, which is a well-established model for testing thrombosis of stents, it has substantially less thrombus deposition than several conventional drug-eluting stents. And obviously, we just came from a session, we were talking about reducing dual antiplatelet therapy, going to aspirin-free regimens. What do we need even more antithrombotic drug on the stent for? Well, obviously, I think it would be still very nice to have something for patients who are at high risk of stent thrombosis, like acute myocardial infarction or complex lesions, especially if they have high bleeding risk. In those cases, it would be nice if we could really avoid any dual antiplatelet therapy. Might be the best of all possible worlds, but we need something more than just one antiplatelet agent in the early time. And so can we take advantage of these locally delivered antithrombotic agents? There may be other non-coronary applications for this type of coating as well, although again, those are beyond the scope of this particular talk. And this concept is being tested right now in a 200-patient randomized trial versus standard DES. So to summarize, no question our current drug-eluting stents are generally excellent, but there still is some room for improvement. We've gotten a lot better, but we have room to go, especially with respect to complex lesions, as well as late stent-related events. The major theme that I see in these new developments are composite designs that provide temporary scaffolding with rapid restoration of vasomotion and flexibility, but using techniques other than bioresorption. These are just techniques where the metal stays behind, but it is dissociated so that it restores a lot of the vessel flexibility and pulsatility. And ongoing trials, and in particular the The Sweetheart trial, the Infinity Sweetheart trial that's going to be presented later this year, will provide the first hint of whether any of the promise of these devices really translates into something beneficial for our patients. Thanks very much.
Great, thank you for this excellent presentation. We move on and have the discussion at the end of this session. It's my pleasure to announce now Peter Smith, going back to BRS Absorb.
Thank you, Bruno. It's a pleasure to talk to you about the future of BRS and the insights from the Compare-Absorb trial. This is my disclosure slide. Well, the Compare-Absorb was a prospective, single-blind, multi-center, randomized controlled trial comparing science versus absorb in a high-risk patient population for restenosis. We know, as also from the previous speaker, that with drug-eluting stents, after an initial uptake of events, you have after that initial period, you see a linear increase of TLF, or lesion-specific events, that goes up to 5 years in all those studies, and we don't see any flattening of the curves. And those event rates is approximately 2% per year. And if we look more closely into this data of a few of those trials that were in this meta-analysis, we see that for diabetic patients and for long lesions and bifurcation lesions and multivessel disease and CTOs, the annual event rate might be even 2.5 to 3.5% per year. We also know that from BRS we get excellent results. We can get excellent acute results, as you can see here in this proximal LED lesion, and that these results are excellent at 1 year, and at 3 years, and at 5 years. And even more beautiful is that after 5 years, when you do OCT, you can here see the proximal marker of the metal marker of the BRS. And here you can see the distal marker that was close to the septal branch, and that you at 5 years you have nothing in between. So there's a beautiful concept of BRS. So our rationale of our study was that we hypothesized that the BRS in a high-risk population for restenosis might demonstrate a better long-term outcome compared to mental deaths. And as we were one of the last randomized studies with Absorb, we also benefited from the previous experiences that we wanted to have an optimal implantation technique. So the objectives of Compare-Absorb were threefold: to show first non-inferiority at 1 year, and then second show superiority on the long term in a landmark analysis, and then also do a tertiary superiority testing on the long term from the start. The patient population that we investigated was the high-risk risk for restenosis, so diabetes patients or multivessel disease patients that were treated with more than one lesion, or they had to have single vessel disease with a complex de novo lesion, meaning a very long lesion or a small vessel or pre-existing CTO or a bifurcation that was treated. This is the trial design. So we initially wanted to randomize 2,100 patients between Absorb and Science. We had this non-inferiority testing at 1 year. Then we're going to do this superiority testing between 3 and 7 years. And the third testing will be between 0 and 7 years. Well, we started in 2015, and we had a good take of our enrollment. And then the initial results came from the Absorb 2, with the 3-year results showing no benefit on vasomotion. And then we also had the alarming results from Absorb 3, with the 2-year results showing an increase of scaffold thrombosis and target vessel revascularization. And that really slowed down our enrollment rate. And when we had at 1,670 patients enrolled, our DSMB recommended to stop the trial based on the increase of scaffold thrombosis and target vessel myocardial infarction that was also observed with the previous trials. So we have now the follow-up of those 1,670 patients, and we have reported the 5-year results, and we hopefully will report the 7-year results at the end of this year, or probably maybe in the beginning of next year. And I want to stress that this is the only trial that is looking beyond the 5 years with BVS. So our baseline characteristics, as mentioned, we high-risk patients for TLF. So diabetics was quite high in this Western Europe population. Multivessel treatment was also very prevalent as well. Long lesions and small vessels. Pre-dilatation, more than 96%. Post-dilatation, high pressure, and more than 90%. So we benefited from all the previous experiences. We've shown that at 1 year we had non-inferiority was reached, though there is an increase of scaffold thrombosis, mainly occurring in the early phase. Now so the current objective is to show you the five-year long-term interim results. And we have a follow-up of, as you can see, at 5 years, still of 95%, which is pretty good. And we also observed that in the absorb arm, more patients keep on having DAPT compared to the science arm. That was, of course, not such a surprise. This is the TLF rate of up to 5 years, where you can see the initial increase in events with the absorb. Then the curves run parallel, and then we see between 3 and 4 years still as an uptake in TLF, and then the curves run parallel or might be even converge a little bit if you look at in this landmark analysis on TLF, where you see the divergence after 3 years still, and a little bit the convergence after 4 years. If you look at the individual components, you can see that this uptake in TLF between 3 and 4 years was mainly caused by the clinically indicated TLRs, and that we don't see any scaffold thrombosis beyond the 3.5 years. So in summary, we see that with 5-year follow-up, we see no significant differences, though the event rates for absorb remained numerically higher, and that this PSP protocol that we could implant, that we could induce from the start, did not prevent the very late events, even between 3 and 4 years. And if I would say what is the future for BRS, I think we should have thinner struts, BVS scaffolds, also a shorter resorption time, the 3 year, or even I think the 3.5 year, I think is too long, and I think we should also benefit from OCT guidance during implantation technique in order to prevent late or early and late scaffold thrombosis. Thank you for your attention.
Thank you. So we'll keep the questions for the end. Thank you so much for that talk. Our next speaker is Dr. Nakazawa from Japan, who's going to talk about novel magnesium bioresorbable scaffold, new insights on next BRS technology.
Okay, thank you very much. My name is Gaku Nakazawa from Kinda University. This is my disclosure. So I'm going to talk about the magnesium alloys bioresorbable scaffold, which is developed domestically in Japan. So in the beginning of the drug-eluting stent era, these dual healing, hypersensitivity reaction, and new atherosclerosis are the main cause of late stent failure. But in the second generation, these dual healing or hypersensitivity reaction is diminished or eliminated by the second generation DES. However, still we see new atherosclerosis even after the second generation drug-eluting stents. Although incidence of the new atherosclerosis is a little bit smaller or less compared with first generation DES. So as you can see here, still you see the foamy macrophages accumulation within the neo-intima in the second generation DES. I think the many factors are associated with neoatherosclerosis, which is vascular factor, patient factor, and mechanical factors. And I think the vascular factor can be maybe minimized by development or refining of the drug-eluting stent technology, or you can modify the patient factors by like a lipid lowering therapy. However, once you put the metal stent, you cannot eliminate the mechanical factors, which is pulsatility or like a conformability of the vessel. Therefore, absorbable devices were expected to solve these mechanical issues. However, like increased risk of the scaffold thrombosis or scaffold stenosis in the late phase mainly due to late discontinuity of the device is reported. Therefore, to overcome these shortcomings of the bioresorbable scaffold, novel Drug-Eluting magnesium alloy-based BRS is developed with thinner struts and shorter degradation period, which is 2.5 years. This is the device description. This material is magnesium without rare earth included, and the strut thickness is 110. And this magnesium alloy is coated with a fluoride-based layer, followed by palladium C. And on top of that, we put the polymer and the silimus. And the entry profile is very low, which is 1.2 millimeter, compared with Avzob GT1 or Magmaris, which is 1.5 millimeters. But this device is 1.2 millimeter as an entry profile. So this crossability is very good. And this is the scheme of the GLP study, which is in the pig model. We sacrifice 6 animals in each time point and followed by up to 2 years after the implantation. And we perform micro-CT analysis, OCT, histology, and SEM-EDX analysis as well. So these are the representative pictures of serial OCT images of JFK1. You can see the slight lumen narrowing after 1 to 3 months, but later on, you can appreciate the lumen enlargement after 6 months, 9 months, and after that as well. Here, this slide shows you that in the beginning of the stent implantation, lumen area is slightly lower than the metal DS. However, after 6 months, lumen area is getting larger and larger. And then that exceeds the lumen area of metal stent. This is a micro-CT analysis of implanted magnesium alloy. You can clearly see the stent scaffold after one month, 3 months, but the resorption is completed almost 50% of the devices at 1 year and almost gone after 18 months. You can see it. And then also 700 days, it's almost gone. You cannot see it. These are the representative histologic sections. After like 6 months, you can still see the scaffold like this here. However, after 360 days, the scaffold itself is difficult to find. And then it's completely gone after 18 months. And the inflammatory reaction is also very small after 6 months. Inflammatory reaction peaks at 180 days and reduces thereafter, and then stays lower up to 2 years. And then inflammatory score less than 1 is very small. So you can see after the 180 days, inflammatory score is close to 2, but after that, it's decreased because scaffold itself is gone. So therefore, inflammatory reaction is also gone after that. And vessel calcification is also occur after the implantation of the magnesium alloy, but the degree is not very extensive, like Magmaris magnesium alloy. And the beauty of this device is shown in this slide. After 1 month after the implantation, you can clearly see the magnesium alloy here, but after 6 months, it's replaced by calcium and phosphate. But this calcium and phosphate is also gone after 26 months. But this is replaced by carbon. Carbon is one of the very common elements of the body. So this means this stent is going back to the nature of the body or vessel. This scheme is shown the behavior of this device after 6 months. Like I said, the lumen area is gradually increased. Of course, the scaffold is start to degrade after 6 months, and along with the lumen enlargement of the vessel is obtained. So summary of this preclinical study shows that OCT analysis demonstrated there was no acute recall or and the vessel patency was maintained throughout the study in all scaffold implanted. Vessel enlargement was observed after 15 months of the scaffold implantation, and the trend was further augmented at 18, 24 months, and the 26 months as well. And the inflammatory reaction peaks at 18 months, but decreases after that. And this SEM-EDX analysis shows that degradation of magnesium alloy was confirmed at 6 months and partially replaced by calcium and phosphate, but calcium and phosphate is also gone after 2 years. And this device is now undergoing the first in-human trial in Japan, and I'm the PI of this study, and target sample size is 30. And this scaffold is implanted in the de novo lesions with 3.0 by 18 millimeter. And 10 sites are now engaging the enrollment. And the 70 patients were already enrolled. And maybe we can finish the enrollment after end of this year. Thank you very much. And then this is the conclusion. Yeah, thank you very much.
Thank you, thank you. Our next speaker is my co-moderator, Dr. Bruno Scheller from Germany, and he's going to switch gears from implanting something to leaving nothing behind, DCB use in your PCI practice, adjunctive therapy or standard of care.
Yeah, thank you very much. It's a great pleasure being here. These are my disclosures. As you can see here from this timeline of interventional cardiology, DCB are not really new technology. We published the first men data in 2006. The first patient was treated end of 2003, more than 20 years ago. And it's interesting to see that after this long time, there's now gaining interest in this technology. I will start shortly with the accepted indication treatment of in-stent restenosis, which is, in my opinion, the worst indication we have for DCB. And this is, here you can see the analysis of the data loss patient level meta-analysis of the trials comparing drug-eluting stent versus DCB in the treatment of drug-eluting stent restenosis. And what you can see here is for the drug-eluting stent restenosis that the efficacy of implanting a second stent, especially in terms of reduction of repeated target lesion revascularization, is higher than for DCB. On the other hand, we can see here that the hard endpoints, death or myocardial infarction, at least tend to be lower when not implanting a second layer of metal, and this is the best argument for DCB use in the treatment of in-stent restenosis to avoid several layers of metal. We have to be aware that these were early trials. When most of the trials were started, there was no idea at all about lesion preparation, that we need lesion preparation. In many trials, there was no lesion preparation at all, or only a minority of lesions. So we had to learn that lesion preparation is key for successful outcome of DCB treatment. And here in this analysis here from Korea, you can see that if you fulfill several quality criteria, which are here diameter stenosis of maximum 20% after your lesion preparation, and adequate sizing of the balloon in a 1-to-1 ratio to the prior implanted stent, then you have very low event rate at follow-up. However, if you do not fulfill these criteria, then you end up with unacceptable high event rates after DCB treatment. In Europe, we have guidelines that are, let's say, a little bit outdated. They are from 2018 for revascularization. And here we have a recommendation for the treatment of in-stent restenosis, either to use a second stent, a drug-eluting stent, or a drug-coated balloon, both with the same level of recommendation, 1A. However, the same guidelines clearly state that they do not recommend the use of drug-coated balloons in de novo lesions. But as shown before, there is some need for improvement of the current generation well-working drug-eluting stent, because we have this device-related event rate in the range between 2 to 3% over time, and as to our current knowledge, this does not stop over time. So what is the idea? It is called DCB only. The focus on your procedure is first related to lesion preparation. No direct stenting, lesion preparation. You have to do the best you can with your lesion preparation, depending on the type of your lesion. And then the proposed quality criteria are diameter stenosis of maximum 30% by eyeballing, and the absence of a flow-limiting dissection. This means type A and B dissections are fine. Meanwhile, many of us also accept type C dissection if they fulfill several specific rules. If this is the case, then the recommendation is not to implant a stent, but to do local drug delivery by DCB, otherwise implant a drug-eluting stent. What about dissections? Dissections are the mechanism of angioplasty. This is well known from the old PTCA times, and it's also well known that non-flow limiting dissections have an excellent outcome. This is newer data from DCB treatments from Bernardo Cortese's group. It could also show that after DCB treatment, you have a very nice healing of the majorities of dissections. There's another new finding coming from the Transform 1 trial comparing the Magic Touch sirolimus-coated balloon with the paclitaxel-coated sequin Blease balloon. And here we can see two different behaviors. Number one, with the paclitaxel-coated balloon, we see a decrease in late lumen loss depending on the dissection grade. This means the higher you dissect, the more you dissect, the less late lumen loss you find. This was not the case with the sirolimus balloon, but this is a very interesting new finding and maybe a new paradigm. What about vessel closure? Here you can see the angiographic sub-study from the Basket Small 2 trial. And we had no single vessel closure in the DCB-treated segments, but a relevant number of closed stents in the small vessel trial. What about the effects after your initial treatment? This is a patient from the PEPGAD-BIF trial. We treated here in both directions with DCB sequentially, and the initial result is not very nice. You have haziness, you have not a perfect lumen, but after 6 months you see that the section is healed, and what you also can see is that the lumen has improved. We gain some lumen over time, and this is documented from different groups here. This was our angiographic analysis at 4 months. On average, we see a shift in the MLD distribution from the left after the initial treatment to the right at follow-up angiography. And again, here from Professor Shin's group, they looked mechanistically with VH, IVUS, and you can see that the main effect of this lumen enlargement is in growth in total vessel area. Furthermore, we have some data, meanwhile, from Japan, for example, that there's also an influence on the volume of the atherosclerotic plaque. And so this is this new concept that we have late lumen enlargement, and you do not need a perfect stent-like result at baseline. Vasomotion. This is a very nice work, also published, I think, from Japan. Yeah. They looked at vasomotion in the stented area versus DCB-only treated area and in the distal part. And it's clear that in the treated segment where the stent is, there is no vasomotion anymore. But with the DCB, you can see very nicely this vasomotion response. But interestingly, it was also better in the distal treated area than it was the case in the stent treated area. One criticism, which is right, is that we have, compared to the stents, a very limited clinical evidence from randomized trials. Shortly, what we have today, the largest trial in small vessel disease was Basket Small 2, 3 years follow-up, 758 patients randomized against Drug-Eluting stent, no difference in outcome. Debut, high bleeding risk patients against metal stents, significant better outcomes. And this is very interesting work, also published by Professor Shin's group. Treatment of multi-vessel disease, either with a pure stent approach or applying the DCB-only concept, which means lesion prep and then deciding if you stent or DCB this specific lesion. And in 1/3 of the lesions, stent implantation was necessary. But look here at the 2 years outcome, DCB group with provisional stenting versus a pure stent group. And I think this is the way to go because we can possibly avoid long-term effects of the stents. This is our meta-analysis as a reaction to the Katsanos paper in the peripheral arteries. We found less myocardial infarction within the first year and clearly no higher mortality when using paclitaxel. So what is the current usage? These are data from the pre-COVID area, 2000. And at this time, the major users were you here in Asia. Japan was the highest, but the rest of Asia also. Europe still a niche, less than 10% use, and the US had no DCB coronary at all. It is, at the moment, it is changing. The US have now approval, and the rates are significantly increasing in Europe and all over the world, and there are some prognoses that say that in 2033 there will be 1-to-1 ratio between stents and drug-coated balloons. So my conclusion is We have stent-related events in the rate of 2 to 3% per year. The DCB only strategy is to reduce the number and length of stents, not to replace stents. Lesion preparation is key, the benefits are late lumen enlargement, vasomotion, and hopefully no stent-related complications. Thank you very much.
Thank you, Bruno. Our last speaker is Dr. Kang from Korea. He's going to talk about real-world data on the widespread use of DCB insights from the IRIS-DEB registry.
Yes, thank you so much. I'm Dr. Kang from Asan Medical Center. And Professor Bruno Scheller showed all the data about the DCB use in the comprehensive review, and I just wanted some small data of our IRIS-DEB registry of the widespread use in all-comer setting of the drug-coated balloon. This is the result, preliminary result from the IRIS-DEB registry that was funded by the Cardiovascular Research Foundation and B. Brown Korea, and this data used the sequent place balloon. And the drug-coated balloon is an attractive therapeutic strategy for ISR or de novo small vessel disease, and is recommended as a class 1A for ISR treatment in European guideline. There's still limited data about long-term efficacy and safety of PCB angioplasty in large-scale real-world registry. The IRIS-DEB registry is an investigator-initiated, prospective, multi-center real-world registry recruiting all consecutive patients who received paclitaxel-coated balloon from 8 centers in Korea. It began the enrollment in 2014 and still recruiting the patient. And annual clinical follow-up up to 5 years were planned, and now a total of 1,000 and about 200 patients were enrolled with a median 36-month follow-up. And interquartile range of the follow-up was 1 to 5 years. And the inclusion is the older patient that was treated with a DCB, and the criteria was the patient who had residual stenosis less than 30% after predilation without flow-limiting coronary dissection. This is the inclusion criteria that was made 10 years ago. And exclusion was the allergic to paclitaxel or other drugs. And study outcome, primary outcome is target lesion failure at 1 year, and secondary outcomes are 5-year outcomes and individual components of the primary outcomes. And this is a baseline characteristics of the 1,000 of the patient. That we cut the patient at 1,000, and that had a median follow-up of the 3 years. And the mean age of the patient was a 66-year-old, and the 60% of the patient was treated for ISR, and 411 patients was treated for de novo. This de novo is a small vessel, vessel size smaller than 2.75, and then use the balloon 2.5 or 2.75 DCB. And 76% of the patient was a male patient, and about 43% of the patient has a diabetes. The proportion of the diabetic patient is very high. One would be because the many of the ISR restenosis patient, and second would be the small vessel disease in the was the DCB would used for the multi-vessel, including small vessel disease. And the LV ejection fraction and total cholesterol level was different, but maybe because the ISR patient has already statin user, so it has a lower total cholesterol and LDL cholesterol level. And the target lesion location was the about half of the ISR patient has LAD disease, and comparing the de novo patient has the LAD and diagonal disease, and the left circumflex disease was more prevalent. Maybe the patient with a small distal circumflex or diagonal disease and OM disease, the operator would prefer the DCB used in real-world practice. And DCB number for lesion was 1.2 in both groups, and mean diameter was 3.0 in ISR group, and de novo patient, the mean diameter was 2.6. And total length was about 28, and the combined was the DES use was the 15% of the de novo the patient. Maybe those patients would use the stenting combined with the drug-coated balloon. And IVUS was used in 14% of the patient. And discharge medication, almost all patients prescribed the aspirin, and more than 80% prescribed clopidogrel. And the statin was used almost all the patient. So the depth was used both in ISR and de novo patient at discharge. And clinical outcome at 1 year, target lesion failure is 3.1% in all patient and 3.4% in ISR patient, and de novo small vessel disease 2.7%. At median 3-year follow-up, target lesion failure rate was 8.3% in ISR group and 3.9% in de novo small vessel disease patient. The cardiac death, the target lesion failure rate was the higher in ISR group, may be related to the recurrent ISR patient. And this is a Kaplan-Meier estimate of the target lesion failure for 3 years. In de novo small vessel disease, target lesion failure was very stable, and the ISR patient was increased in 1 and 2 and 3 years, maybe related to the clinical follow-up. And we evaluate the risk factor for target lesion failure by Cox proportion hazard model. The ISR type and the presence of the diabetes and the higher number of DCB was the predictor of the target lesion failure. And the IVUS during the procedure was also a predictor of the recurrence. That would be maybe the complex lesion or recurrent lesion. The operator would use more IVUS. That would be the cause I think. And this is conclusion. IRIS-DEB registry is an investigator-initiated prospective multi-center real-world registry of the all-comer patient who received paclitaxel-coated balloon in South Korea. And DCB angioplasty with paclitaxel-coated balloon showed favorable 3-year clinical outcomes after treatment of coronary ISR or de novo small vessel disease. Thank you for your attention.
Thank you very much. I would like to start with one question to the panel. We heard about different technologies, stents that will not be permanent for all the time, or parts of the stent will disappear. And for DCB, we're also saying we have vasomotion from day one. I'm wondering sometimes, vasomotion is nice to see, but does it help the patient? Is this really a goal we should have?
I can't remember the last patient I saw at clinic who said, I don't think my vasomotion's right. You know, I think it's not really an objective of theirs. It's reduction in symptoms and getting them out of hospital. So I think it's laudable, but you know, you keep seeing this graph of the 2% accumulation of events, but there's no OMT with people with coronary disease in that. And if you look at ischemia and other populations for the OMT groups, there is an accumulation of events. And I think it's a little bit naive to believe that a DCB or a BRS concept is going to mystically take all of these events away. I don't think that's likely to be the case. So are they going to be hugely better over a 10 or 20 year period? I'm not 1,000% convinced so far, and on the basis of the data we have, we are none the wiser. And the reason for that is data that Peter showed. You know, the stent implants in the trials that compare the use of these technologies has been horrific, with 50% post-dilation in science. You know, basket small and hardly any IVUS in it. If we have gold standard DES implant with image optimization versus whatever, then we can start to have a conversation about what really benefits our patients the most. And right now, I don't think we're really any the wiser. It's a lot of anecdote.
I mean, I think to track on that, I think we all agree that there's certain areas of need, right? Putting stem to stern metal into someone's coronary is not a good idea, right? It really traps you.
Yeah.
On the same token, like Simon is saying, in the proximal LAD, when you're going to put in a 3.5 stent and post-dilate and have a minimum lumen area of 13, that patient's going to do pretty darn well. But we all see these patients diffusely diseased, distal LAD. We don't really want to stent them. You're going to end up with a small MSA anywhere. Maybe that's the place to take advantage of positive remodeling, drug-coated balloon. You can tackle the dissections, and hopefully it remodels in a meaningful way.
I use a lot of DCB. I mean, I'm not here to diss the technology in any shape, form, or fashion. There's a gazillion places you don't want to add metal, graft attachments, small vessel, small branch, many, many clinical scenarios. So there's definitely a good place for these things, but I think the imperative responsibility on the collective of us is to actually produce really high quality evidence to answer these questions definitively. And I think we've got a bit of a sort of mishmash of stuff that's not great at the moment, and we're not in a good position to make good, sensible decisions for patients in a lot of scenarios.
So in that light, my question actually to Bruno, to you, was that, conceptually, it makes sense to not put an implant. We use a lot of DCB in our practice, and I think all DCB operators have excellent anecdotes of, great cases we did, and, 6 months, a year later, the artery looks beautiful. But my question to you is that we haven't seen the large-scale outcomes-based trials in the space in any subset. I mean, the largest data set is for ISR. Maybe basket small for small vessels is the next data set, but where are the large-scale trials? And then also in subsets, bifurcation being one. So what is the barrier to those trials? And this is to you, Bruno, to you.
For me, two main reasons. Number one, our misconception in the beginning was to focus on instant restenosis. This was, it was accepted because the stent is already there. But the strength of DCB treatment is to have an uncaged vessel, which you allow to grow a little bit, and to have its physiological function. And I mean, the ISR case was clear. That was an easy job to get the 1A recommendation. But at the end of the day, all this work that has to be done, large-scale randomized trials, creating the evidence for de novo disease, this did not happen for a decade, and that's one of the big mistakes that were done, in my opinion.
I mean, I think we still have to wait now for the solution trial. I mean, it's a large worldwide randomized trial, and excluding CTOs and left main, and it's on hard clinical endpoints. 3,000 patients will be included, so I think there are still 800 or 700 left for the inclusion. Then we'll have to wait for the outcomes to have clear evidence about that.
But even then, Kambis, unfortunately, it's not image optimized DES implant as the gold standard comparator.
Agree. I mean, at the moment we still have a little bit problem to define what is a good outcome with DCB. You've seen there's an FFR measurement more than 0.8 acceptable outcome. We don't know about in the recommendation paper, right? On the other side, we don't have clear imaging data which correlates to good DCB outcome. So we know the large dissection might be a problem. And but what is a really good imaging correlated outcome of the DCB? It's quite the criteria missing. Agree on that point, right?
Yeah. I have another point, Beck. Look, I'm big user of DCB, but whenever I get questions from the DCB critics, they say to prepare a lesion use scoring balloon, cutting balloon. Whereas for a stent, if the balloon is expanding, I go for a stent. So you're basically adding the cost of scoring and a cutting balloon, and then the DCB, which are twice the price of the stent. So it's very difficult to answer unless we have a data showing that it is superior. Even solution large, I'm a bit skeptical. In the first few years, it will not show any superiority. Maybe in 10 years, the curves may separate. But the first 3 years, especially if you're putting a 3.54 millimeter stent and comparing with the DCB, I'm not sure you'll see a superiority.
And we have to be careful. There are different technologies. I think for paclitaxel is more forgiving, independent of the technology used on the balloon. But for sirolimus, the technology and the persistence of the drug will be key. And that's one of the issues we have with sirolimus, because we do not know if such a trial-like solution would not be successful. Is it the technology of the specific balloon, or is it the idea itself, and that's one of the other issues. In parallel, we have other trials ongoing. The reverse trial is ongoing in this this area at the moment. All comers, we are planning basket B all, also an all-comer trial. And there's a large trial with the European Bifurcation Club in planning DCB against Stent strategy. So there will be additional data in the future, but it will take time.
So I want to ask something to the panel as well. So isn't there a little bit of hypocrisy between BVS and DCB? So if you removed the name of absorb and you put DCB, everybody would say, this is fantastic, right? Just a small increase in target vessel failure rate seems to do fine. Everything vessel is gone. But when we do that, the same thing, and put a BVS, then the outcomes are much, much worse, and the critic is much larger because there's a scaffold. So the current data shows that your 1-year target vessel failure rate with a DS inside in-stent restenosis, for example, is 7%. Agent just got published, it was double that. So the gold standard for a large vessel should still be a drug-eluting stent from a cost point of view as well as from an efficacy point of view. But then if you do the same thing for BVS, it's completely different standard.
I think the problem wasn't the technology per se, because it was made for really type A disease, and that's where it was tested and looked promising at the start. What happened was it got rolled out to the world and people started to do really stupid stuff with it, and they were putting it in 2-stent bifurcations and like 10 feet of disease and unprepared calcium. It was just going to be a car crash, and that's what it turned into. So I think DCB paradoxically is a little more forgiving because you're not putting that mess of Lego bricks in on top of the rest of it in the complexity scenario. So to me, I think the DCB concept in the broader world is probably less likely to be associated with those adverse events than a resorbable implant. Anything that's not done well is going to compromise the patient outcome. That's the bottom line. And if we do DES really well and we image optimize, and patients get a great result. You know, so that's our baseline.
Major concern, I mean, what I get from the BVS was just the scaffold thrombosis and the late thrombosis as well, right? And you could observe that over the years. At the moment, I don't see that with the DCB, and well, we'll still have to wait. But the fatal events that we had, that they were a little bit scary.
I think that's one of the advantages now of the next generation, right? So first of all, I think we would all say that we would perform an imaging-guided placement of a BVS, which we didn't do in Absorb. And second is the struts are much, much thinner now. And so, you know, as Simon was saying, if you do the math, right, you have a 2.5 vessel and you put overlapping BVS, do the math, right? 150 microns on each side, 300 microns plus 300 microns, that's 600 microns. You just created a stenosis. It's crazy.
Yeah.
But now we need to get back to, you know, thinner struts, putting these in more applicably in better milieu, larger vessels.
Probably also best treatment of care will be a hybrid approach in future, right? Because we always tend to compare things, right? Shockwave, rota, right? Things like that. But in daily practice, we combine them, right? And that also have shown your data, basically, that the combination here, when you had only used 1/3 of drug-eluting stent and the rest was DCP in a real data population, real world population, basically data were not so bad in commerce, all in commerce.
So I do use DCB, but I would like to remind the initial purpose of development of a stent is to prevent acute closure and make sure the successful PCI. So I do not object to the widespread use of DCB, but if you are not confident for the procedural success, just DES.
But a lot of it is also the mindset. I mean, in the US, you think people are going to be happy to leave dissections, type B dissections, and go home and use DCB?
It's going
I
to
mean,
take
so a lot of it is mindset and
it's gonna take
retraining, which
people
is
time to learn, but you know, it's an interesting scenario in the UK. I think where DCBs are used, actually proximal DES, maybe side branch or distal DCB, the combination is more than 50%, and that would probably reflect my practice, where it's proximal stent implant and then DCB for other bits, unless it's a very specific scenario.
I think where the need is, along with the randomized controlled trials, is a lot better data on the metrics for success, like Kambis said, right? I mean, this FFR 0.80 is just completely made up, right? Just, I mean, well, you could say that the same thing for a drug-eluting stent, right? So, but that doesn't tell you whether or not you're going to acutely close your vessel, right? If you have an FFR of less than 0.80 or greater than 0.80, certainly doesn't predict your long-term outcome. We have no idea of what dissection is dangerous, what dissection is not dangerous after you leave it. And Bruno, as you quite astutely said, I don't even want to look inside after I've done it, because I know it's going to be torn into shreds. So, you know, those are the call to arms and the call to action for all of us when we start doing this, when we start doing it in the US, collecting this data meaningfully to help see exactly what heals, what doesn't. Maybe that's where we need to go.
Hongbang, you have a question?
Yeah, Fahim, since you are all the thought leaders here, as much as a comment and question, I think I agree with some of the points made. I just want to say something as much as a comment as a question. Conceptually, we had to rethink about how comparing devices, like you said, it's probably not just about head-to-head comparing devices now. We had to look at them in terms of strategy. And perhaps it should be something like how we look at antihypertensive drug. We move away from head-to-head comparison. We look at concepts of combination. We look at, you know, let's say, a RAS-based approach versus a beta-blocker-based approach. So likewise, we probably think something along that line. Like you said, the reality is many of us will use these things in combination and hybrid, often not as a bailout, but upfront. So that's one thing. The other thing is I think we had to relook at how we look at outcome. Where we do something where the existing standards are so good, it's always very hard to beat it.
Yeah.
Take, for example, for instance, now you have a NOAC and factor 11A coming in. It's not easy to show superiority. We continue to think that methodologically, that we had to show kind of, hey, non-inferior, right? But in time, if you really want to say, hey, this is something, is a new paradigm, what we're going to do? Measuring zero is never easy. Doing preventive studies is never easy. You have to rethink about it and say, maybe I look at how other people do other things, right? Like cancer people, they look at, well, instead of looking at effectiveness and safety, they look at other ways. You know, no one look at survival alone anymore. For us, we should not be looking, for instance, like just MACE and bleeding. There are some of these analyses like MACE-free or first event, like heart failure. We have to rethink. So maybe I suggest the next consensus meeting, wherever we are in, whether it's an international, whether it's an Asia-Pacific, whether it's a European, or in time, if we ever can get ourselves together, a global one, there should be a paragraph and section where we all sit down and talk about future research and how to look at measuring outcomes. Just a suggestion.
Yeah, an ARC DCB might be a helpful thing.
Yes, yes, and so far, and the improvement of the better outcome after DCB treatment is just almost related with the decreased stent burden, especially in the small diameter stent. So, and I think DCB is very nice complementary to make the complete revascularization.
Yeah, but one comment, ARC DCB will be published, I think, at EuroPCR. We go online, and it's an attempt to do some standardization for trial design.
Well, it's going to be the Wild Wild West starting on Monday. So we're about to, the first drug-coated balloon actually will be on Tuesday at our institution. And so we'll see what happens.
But I think the cost for you is what, $5,000?
$5,500, yeah.
For a DCB.
I'm going to ask Simon to bring some in his bag.
Don't forget the platelets.
That's
right. Okay, great. Any other comments, thoughts we have to discuss now? Great. Thank you so much. It was a great session and for attending it. Thank you.